Hello and welcome to ADAA's 2022 Virtual Fall Forum on Psychedelic Therapy, Problems and Promises. My name is Sanjay Matthew. I'm the Chief Medical Officer for ADAA and a professor at Baylor College of Medicine, and I'll be your moderator and host for today's webinar. Before we get started, I'd like to go over a few technical details. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. To receive your CE or CME credit, you'll receive an email after the session with the link and instructions. We're delighted to welcome our speakers today. Please note you can submit questions through the Q&A feature in your attendee interface, and you can send in your questions at any time. So we welcome the keynote speaker, Dr. Gerhard Harris, and our panelists who will be in the next hour, Dr. Stephen Ross, Rachel Yehuda, and Greg Fonzo. We thank ADAA for its sponsorship and our attendees. So to start with, by way of introduction, Dr. Gerhard Harris is the Ralph Metzner Distinguished Professor in Neurology and Psychiatry and Director of Neuroscape Psychedelics Division at the University of California, San Francisco. He moved to the Imperial College in London in 2008 after obtaining a PhD in psychopharmacology from the University of Bristol. He has designed many brain imaging studies with psychedelic compounds and has conducted clinical trials in this area. He has authored over 130 papers with over 14,000 citations. He founded the Center for Psychedelic Research at Imperial College London in 2019, and in 2021 was named in Time Magazine's 100 Next, a list of the 100 rising stars shaping the future. So we're thrilled to have him as a speaker, and he'll be talking about brain mechanisms of psychedelics. Welcome, Robert.
Thank you very much, Sanjay, and really pleased to be with you all. I hope you can see my slides and they're in a good format. Yes, very honored and privileged to be giving this talk. Thank you to the organizers for having me on to do this. So I'll take you through my presentation on psychedelics and my understanding of their action in the brain and their therapeutic action. And I word it in this way because this field is moving very fast and there is a very healthy diversity of opinions and models now for the action of psychedelics. So I do encourage you to do your own research and test all assumptions, and that's the wonderful thing about science. So here we are looking at the target receptor that classic psychedelics seem to initiate their action at. It's the serotonin 2A receptor. We can see where it's expressed in the living human brain here with a pretty selective serotonin 2A receptor agonist ligand. So that allows us to label the receptor in its functionally available state. So this is arguably the most informative map of where functionally available serotonin 2A receptors are in the living human brain. You can see that they're heavily expressed in the cortex. And
Robin, if I could just interrupt, the slide isn't advancing.
Okay, and I'll close this because, right, and I move this. Okay, so let's get back on track. So the 2A receptor is where classic psychedelics initiate their action. They're all molecules that will initiate signaling at this target receptor. We know that this receptor is key to the action of psychedelics because first of all, there's a tight relationship between the affinity of a range of different serotonin 2A receptor agonist psychedelics and their potency. So the higher the affinity, the higher the binding potential for the 2A receptor, specifically, the higher their potency. And as things presently stand, we haven't found such a relationship for any other receptor in the brain and the potency of psychedelics. So a little bit like, D2 affinity and dose of antipsychotic drugs, effective dose. You've got a pretty reliable association here between the 2A receptor and the action of classic psychedelics. Also in humans, if you pre-treat with a serotonin 2A receptor blocker, you will significantly attenuate the classic characteristic psychological effects of psychedelics. So there's a few reasons why the 2A receptor seems to be very important. Where we are right now is that there is some interesting works just sort of questioning whether there's a specific signaling pathway that is specific to psychedelics, that you have to stimulate the receptor in a particular way. So the field's moving and becoming more nuanced all the time. Now, I really want to show you my different slide animation components. This might trip me up a little bit. At the moment, I'm sort of unable to do that, and I really want to see if I can make that work. But this isn't working. You can't see my. No. Okay. Let's go back and not complicate things. Right. So the next question that follows would be, if we know that the 2A receptor is key to the action of psychedelics, what does it do? What do we know that it's involved in? I would say beyond just the action of psychedelics. And there's a wealth of evidence, you can see it cited here, that both serotonin and the 2A receptor specifically are involved in plasticity. And I intentionally word it that way, consciously if you want, because plasticity is an umbrella construct that, if you look it up in the dictionary, would read something like the ability to be shaped or molded. And in my view, being faithful to that definition, that applies to both behavior and psychological traits, as well as neuroplasticity. But if we go into neuroplasticity specifically, there's a bunch of different markers that we could look at and see evidence of those being upregulated or increased with exposure to psychedelics. We can also look at brain development and evidence of a role of the 2A receptor involved in different components of growth in very early brain, in embryonic brain. 2A signaling actually seems to grow neurites or pre-neurons. Their proliferation seems to be under the control of 2A signaling. So cortical expansion there, 2A signaling seems to be involved there in the very early embryonic brain. Also a role for the 2A receptor in learning, associative learning, low-level learning, implicit learning. If you want, you can see this nice chart looking at learning rates in rabbits. With exposure to LSD, learning is accelerated. This is actually a micturition response, air puffs into the eye. The response to that, and that being accelerated with LSD, and actually slowed down with ritanserin, a non-selective 2A antagonist or blocker. So evidence for a role of the 2A receptor in accelerating learning rate that feeds in very neatly, I think, to plasticity broadly defined. And we can look at some other components. We can look at psychological flexibility, the ability to sit with difficult feeling states and memories, a component of the psychotherapeutic process, arguably a key aspect of the action of psychedelic therapy. We can also look at cognitive flexibility, those paradigms that translate quite nicely between species, and look at the ability to change behavior with changing rules. We can also look at environmental sensitivity, and of course that's implied by a plastogenic compound. If it is increasing even, markers of neuroplasticity, if we're being specific, we would call it heterosynaptic plasticity. But the implication of an action like that arguably would be that the animal would be more sensitive to environmental conditions. And I'm going to argue that that's highly suggestive of what psychedelic therapy is. The spoiler that I'll give you now being that it's a combination treatment. It's not just about giving a drug, it's about combining a plastogenic drug with, if you want, manipulation of contextual conditions, or in other words, psychological support. So also setting a bit of context for the 2A receptor and its functioning, we can find in the literature that certain conditions do seem to modulate the expression and functioning of the 2A receptor. And those conditions are conditions of adversity. Chronic stress paradigms seem to quite robustly and reliably upregulate 2A expression, here with hypoxia, shortage of oxygen, here a chronic stress paradigm, and we're looking at a behavioral readout of 2A signaling with the application of a 2A agonist after chronic stress. And similarly here in another study where the conditions of maternal separation and chronic immobilization stress, and then a big readout of a marker of 2A signaling with application of a 2A agonist. And then we can look at acute stress, and that's arguably, short of giving a drug, the most reliable way to release the endogenous ligand for these 2A receptors, which of course is serotonin. And you can see different types of acute stress causing a marked release of serotonin there, different aspects of the brain. Just a little reference at the end that it might be surprising to some people that acute stress is another intervention, if you want, or conditions under which you can promote neuroplasticity, in this case, brain-derived neurotrophic factor in the prefrontal cortex of animals. So what's the big picture here in looking at this? And it's really speaking to the function and the evolutionary function of the 2A receptor, and submitting the idea that it exists for behavioral flexibility or adaptability under conditions of adversity. So adversity engages what you might call a plasticity and adaptability system. And that's covered in this somewhat rich perspective piece, Pivotal Mental States, that I encourage people to check out. These states, just briefly, could be defined as states of hypersensitivity to environmental conditions, hand in hand with a plastogenic action. And so those environmental conditions become pivotal as to where the agent, the animal, the human goes under those conditions of hyperplasticity and hypersensitivity. Now, I've got a couple of models in here. Let's see if I'm going to be able to show you, but really this is to take us more or less up to speed on the latest clinical evidence for psychedelic therapy. And I highlight in red some take-home messages that I'd like to emphasize. One is that all of the human studies that have been performed to date have manipulated contextual conditions in a particular direction, in a positive direction. In a sense, they've enriched the environment with things like two compassionate, often two beings there for the individuals during the session, music listening, I think, without exception in all of the clinical trials, psychological support before, during, and after. So this isn't a trivial detail. In a sense, you know, these studies are looking, you could even say it's psychedelic combined with, you know, music listening therapy, but that doesn't often get highlighted. But it's important to reflect on because perhaps, you know, there's an argument for a lack of translation into some of the animal models. If this, you know, key factor that's there as a staple component in all the human clinical trials that are showing signal is missing in models of psychedelic therapeutic action. We should also think about the kinetics of the action, its speed. It's very rapid, like with ketamine. You see improvements as soon as the next day. I'm not convinced by these hour by hour improvements, but I think it's reasonable to look the next day, and there you will see marked drops in depression symptom severity, for example, with psilocybin therapy. It's enduring action as well, seemingly more enduring than a single administration of ketamine. A single administration of the classic psychedelic like psilocybin seems to be more enduring in its improvements. And at least as important, if not the most important, potential advance of psychedelic therapy is this putative transdiagnostic action, that this modality, this approach may target what I would call a core common denominator to psychopathology. And I think that's especially exciting, and we'll come to that in a moment. And also just to emphasize, in line with what I've already been saying, that psychedelic therapy is a process therapy. It's not a one and done kind of model. There's a reason why there's psychological preparation ahead of the experience, and also what we call integration work after the experience. And that's important to emphasize. You can see one model of a few that we've been developing with collaborators. And here, you won't quite be able to see it all, but I'll play around with a screen to show you that emotional breakthrough rated shortly after the experience, after people have come down from the acute action of the drug, and they rate the level of emotional breakthrough that they experienced during the session, seems to be arguably the most robust, and in our data at least, because not everyone's using this measure, emotional breakthrough inventory. I wish they would, but cognitive diversity. It seems to be reliably predictive of improvements in mental health outcomes. And actually, in this particular model, we measure psychological insight with a scale that's done post-acutely after the event, includes items like, here I show them, I've had important new insights about how past events have influenced my current mental health and behavior. So emotional breakthrough, in a sense, mediated through psychological insight en route to improvements in well-being. And this model seems to be holding up pretty well in our data so far. Let's see if we've got another. Okay, what else have we got hiding? Well, let's just move on, I think, to the next slide, where we see another model. And this is showing that another key component of the process of change with psychedelic therapy seems to be the therapeutic rapport that a patient feels with those individuals attending to them during the session. And actually, this rating was just a single VAS item, which reads, I have a good relationship with the main person or people who'll look after me during my experience. And we've seen that this is predictive of, this rated on the morning of the experience before dosing is predictive of that seemingly pretty important emotional breakthrough experience en route to improvements in depression symptom severity. So this is in our recent controlled trial of psilocybin therapy versus escitalopram for major depressive disorder. So those are two suggestions, but you can see that this is the suggestion, really, that the evidence is that this is more than just a drug action, that there seem to be pretty important, what you might call extra pharmacological factors that are moderating or mediating response. Now, this is a busy slide at the best of times, but especially so when you can't get the animation working. And so I'm just going to give you the high level, in a sense, let your eyes glaze over and don't get lost in the detail, and perhaps just listen to me. And here, the entropic brain principle, something I introduced in 2014 and updated in 2018, is a very simple principle, which says that if you measure the complexity or entropy of spontaneous brain activity, then there will be a mapping between that and the richness of conscious experience, the richness of content of conscious experience. And that principle seems to be holding up. It works especially well with electrophysiological data recorded from the cortex, actually across species. And it's not a rule, and it never was a rule just for psychedelics. And this is a thing I'd like to emphasize, that, you know, in a sense, what drew me into psychedelic research was the sense that these are tools, you know, but let's not get too attached to the specific tool, but rather use the tool as an opportunity to understand the mind and the brain and maybe psychopathology. And I think this principle works in that sense because there's a variety of other states that are, in a sense, share some aspects of the phenomenology of the psychedelic state, and also show this increase in the complexity or entropy of spontaneous activity. They include meditation in experienced meditators, in REM sleep and dreaming, with music improvisation, in the preictal aura of temporal lobe epilepsy, and also fluid intelligence seems to track signal complexity in the brain. And flip it the other way, look at states of reduced conscious level or conscious content or richness of conscious experience, and very reliably you'll see a decrease in signal complexity or entropy in the cortex, so much so that this metric can be used to determine the dose of an anesthetic, for example. Evidence for psychedelics increasing signal complexity is enriching all the time. This a small sample, but a nice one, currently unpublished, but under review in PNAS, where we directly ask people to rate the richness of conscious experience and then track signal complexity or entropy with EEG in people administered DMT. And so pretty tight relationship there. You'll see another finding later on that appeals to the therapeutic action as well. Quick check of time. So this is perhaps the most sort of freshest thing in my mind at the moment. I've just finished a major review paper that is a multi-level and approach perspective on the nature of psychopathology. So taking inspiration from the work of the likes of Caspi and the notion of a very parsimonious model of psychopathology or mental illness, one that plots it on a single dimension. And I like this, you know, it's daring and bold, and of course, it's a parsimonious model, so it won't explain everything, and it'd be very challenging. It is very challenging for people. But the point of a parsimonious model is that you could explain potentially a lot with few parameters. And I think that's appealing, and I think it's appealing in the context of psychedelic therapy. And what I want to submit is this idea that, and this is what I argue in the paper, that a key, arguably the principal component of psychopathology, downstream of an initial period of distress or dysphoria, typically linked to adverse conditions, trauma, adversity, complex trauma, if you want. Downstream of that is the reaction to those conditions, which I borrow this construct from evolutionary science, canalization, which is in a sense the inverse or the converse of plasticity broadly defined. If plasticity broadly defined it means the ability to be shaped or molded, then canalization is a resistance to being shaped or molded. It's being stuck in a particular way. And what I'm arguing is that that's the common denominator in psychopathology after the initial period or periods of distress, uncertainty, and or dysphoria. So in a sense, you could argue it as a sort of functional response, functional in inverted commas, of course, to conditions of adversity. And I think that presentation can be seen in a variety of psychiatric diagnostic categories like obsessive compulsive disorder, getting stuck on whatever the obsession is or the compulsive behavior linked to a obsessive or intrusive thought. Negative cognition, the negative cognitive bias in depression, again, getting stuck in that rut, reinforcing that and those assumptions about the self being bad and worthless and life being pointless and so on, rehearsing that, entrenching that all the time. I'm arguing, a bunch of different psychiatric diagnostic categories can appeal to this principle of entrenched ways of thinking and or behaving being a common denominator to psychopathology, and using the principle or going by the principle that a solution can often reveal the problem in a sort of, reverse way. And I think that's what's emerged in my mind with psychedelic therapy, is this thought that there can be signal in a variety of different diagnostic categories, symptom presentations, then maybe that's because it targets a core denominator, and that's where the model emerged from that thought. Now, if we leave the trenches and transition a bit into a separate but related question, which is what's the acute action of psychedelics on the brain? And here I present a few different findings appealing to a similar principle, which is a increase in communication across systems or modules in the brain under drug, something that we've seen with psilocybin using fMRI, and something that we've seen with LSD and others have as well, where in this case the primary visual cortex is communicating with other modules that typically it doesn't communicate with so much. This was with eyes closed, and the effect correlated with the complex imagery that people rated, the intensity of that imagery that they rated after the experience. And we've also seen it now with DMT, where these hot regions are communicating with the average activity of the rest of the brain, or if I put it more simply, just the rest of the brain. And so in a sense, they're breaking their bounds and becoming, more communicative with the rest of the brain. And we can dive into that by looking at the dynamics of brain activity. So rather than just doing simple time averaging, what if we look at substates, if you want, and their transitions across time? This is a really hot space that I think is going to shed some important light on the action, the acute action of psychedelics, and actually its therapeutic action as well in the coming years. But this particular finding, which is a replication of what we've seen with psilocybin and LSD as well, here we're looking at DMT, shows that high-level modules or systems or networks, like the default mode network and these frontoparietal networks, are, in a sense, visited for less time under the psychedelic. They're sort of being skipped over in a sense, probably because their boundaries are breaking down as they communicate with the rest of the brain. And so rather than see a finding like this one and think that somehow are these regions becoming, more active or something in a simple way, and it's not really that. It's that their activity is dysregulating, opening up and becoming more communicative with the rest of the brain. And actually that translates, in a sense, to those modules diminishing, you might say, in their specificity. And for me, this is a tantalizing, invites a tantalizing thought that this could correlate with some of the high-level psychological aspects of the psychedelic experience, such as so-called ego dissolution or ego disintegration, that these particularly high-level systems corresponding to high-level human evolved cortex, they're then being diminished in their visitation time under drug, could relate to that experience. We'll have to test that directly in future work. What about a related but sort of follow-on question from looking at the acute action of psychedelics, which is what happens in the brain after a psychedelic experience? And in these data that we'll look at, what happens in the brain after psilocybin therapy for depression. So we did this initially by looking at brain modularity in a study of psilocybin therapy for treatment-resistant depression. And we looked in the brain one day after the second of two treatment sessions with psilocybin. This was one day after a 25 milligram dose of psilocybin. And what we saw was a decrease in modularity in the brain that correlated with improvements in symptom severity at time points, in this case, 6 months, quite far off. So a brain change at one day post was being predictive of improvements 6 months down the road. Perhaps a word on modularity, it relates in a sense to what we've been looking at in terms of the acute action of the drug. Modules becoming more communicative with regions outside of their typical boundaries, and also less tightly coupled in terms of the regions within a module. So it combines both of those components, and a decrease in modularity would translate into less coupling between regions within a module and more coupling or communication with regions from the module outside of the module. I hope you follow. And we replicated that finding in an entirely independent study and sample, and we again found it correlating with improvements in symptom severity, this time at the primary endpoint, 6 weeks post-treatment. We also saw that this action especially implicated high-level brain networks, recapitulating the acute action of drug. In this case, it was actually the executive network that was decreasing, especially decreasing the modularity, meaning regions within that network are communicating with regions outside of that network or module post-treatment. So that's what we have. Very much needs replication. Excited about that it be tested. Please look at modularity in any fMRI data sets that you have. Let's see if we've discovered something here. But the model could be communicated through this schematic. And again, it brings us back to that model of psychopathology itself, that people literally, as a kind of defensive response to the vicissitudes of life, can get stuck in ruts. And this model works quite neatly with depression, because you can depict it as a literal depression in an energy landscape or state space landscape, where it's very easy to fall into this rut and difficult to get out of it. And the model is this, that the acute action of psilocybin will flatten that energy landscape such that there's more flexibility, more easier transition within that global state space. And then this recent finding published in Nature Medicine is suggesting that there's some kind of carryover of that effect. So rather than falling back into the old ruts, there's some kind of flexibility that's preserved post-treatment. It carries some intuitive appeal, but of course, it's all about replication, and we will test whether this holds up. Now I'm presenting some fresh findings here, currently unpublished, but very exciting, which was in a healthy volunteer study, where within this study, we combined different imaging modalities. We did MRI and fMRI before and 1 month after doses of psilocybin in these healthy volunteers. And we also had an EEG cap on during the sessions themselves. And the design was, we would do baseline MR, and then 1 month after a control dose of psilocybin, a placebo dose, 1 milligram, very low dose, doesn't seem to appreciably change brain activity in terms of EEG, 1 milligram. So we'd scan baseline 1 month after 1 milligram, and then 1 month after a big active dose, 25 milligrams, so 25 times the amount of the control dose. And we look in the brain again. Let's look to the EEG first. This is a visual LTP paradigm, so a functional index of what you might call Hebbian plasticity, priming the brain in terms of a particular response, particular evoked response, with a kind of priming paradigm, call it tetanus. And then under the big dose of psilocybin, we saw an augmentation of an index of enhanced sensitivity to that priming or that training, if you want. And this is considered a index of long-term potentiation based on some translational work, looking at that more directly in non-human animals. So it could be considered evidence of functional plasticity in the human brain here with psilocybin. So that's what we saw under drug, and we didn't see it under the control dose of 1 milligram. But arguably the more exciting finding was when we looked at the tractography data 1 month after 25 milligrams of psilocybin, and there controlling for multiple comparisons and constraining the state space or the test space to some major tracts in the brain. We saw that 2 tracts survived correction and changed after the 25 milligrams and not after the 1 milligram control. So 1 month after 25 milligrams, healthy volunteers, entirely psychedelic naive when coming into the study, they showed enduring anatomical brain changes after this big dose of psilocybin. So you can imagine, very excited about this finding and currently working on the manuscript for submission. But what were the tracks? Well, there were major prefrontal tracks from the prefrontal cortex into the thalamus and into the striatum. And here those tracks are combined. And what was the direction of change? It was a decrease in axial diffusivity. So just to provide a bit of context, if you look at aging, this is something that you would see from an infant brain into adulthood, decreases in diffusivity as the brain matures. But then if you look at the other tail of aging, an aging brain, then diffusivity starts to increase. So, let's not get too carried away, but it's interesting, and it's in a direction that is more, I would say, exciting than concerning, you might say. So I'd like to just, there's a lot of brains here, but there's a point to be made, which is there's a consistent pattern when looking at a bunch of different metrics, whether they be functional, molecular, or anatomical. We can look at a molecular one and see where the 2A receptor is, and that it seems to follow a certain gradient with high expression in especially evolved cortex, association cortex. Then you can look at brain expansion, evolutionary brain expansion itself, with, in this case, macaque to human expansion, and see that the regions that have high expression of the 2A receptors are human evolved cortex. They're also developmentally evolved cortex. Here's the principal gradient, or if you want, the main dimension by which functional connectivity is organized in the human brain, which clearly and neatly separates high-level transmodal cortex from lower-level unimodal cortex. Longer fibers in this high-level pattern, this evolved, human-evolved cortex, greater inter-subject variability and functional connectivity. So arguably it's a more plastic, less entrenched, less canalized system. Lighter myelination, which you could relate to that. It's involved in processing more abstract semantic information, longer temporal windows. It also seems to correspond to slow fluctuations in arousal picked up by physiology, and how the activity travels across the brain in relation to those slow fluctuations in arousal levels. And we can see that psychedelics seem to target this gradient. So what is the high-level picture here? It's really, in my mind, suggesting to us that psychedelics impact a major aspect of brain organization, maybe the principal aspect or dimension of brain organization. And I think that's quite exciting because it says that psychedelics do something major to the brain, you might say. And no surprises there, you might say, but I'm not sure that's always super clear. And, you know, there's a lot of noise that could get in the way of, in a sense, quite a simple picture that could speak to why these compounds are so interesting and have such profound effects on human conscious experience, because they target a key, if not the principal, dimension of organization of the human brain. So let's move on, and I'm mindful of time. We're at 46 past the hour. So I hope you allow me to just finish, and to do that, I'd like to go into therapeutic mechanisms and here tell you a little bit about the Rebus model, relaxed beliefs under psychedelics, which borrows from predictive coding and essentially says that what psychedelics do is that they modulate the precision weighting of assumptions that we hold in our cognition and our behavior and our perception. It's the weighting of those that is available to modularity, not necessarily the assumptions themselves, but their weighting. Here's a little bit of evidence in that direction, where we can look at information flow in the brain via traveling waves recorded through EEG. And the short story is that, as we predicted under psychedelics, there's a flip in the directionality of information flow from a usually dominant top-down influence to a more dominant bottom-up influence under drug, suggesting that this is encoding the precision weighting of the top-down, of the assumptions held in the model of the world and self that the brain is, and that allows for information to percolate up into conscious awareness. We've measured this directly in terms of the psychology and in terms of the mapping between precision weighting as encoded in the brain and actual confidence in beliefs. In this case, these are healthy volunteers, but everyone has lived a life and can have complexes and hang-ups. And so we ask about negative self-beliefs, and we see that confidence in those beliefs dials down under drug, and interestingly, 1 month after drug as well. And we saw that the signal complexity or entropy in the brain recorded with EEG during the dosing session related to this effect, both the acute effect and the enduring effect. So that was quite a nice, in a sense, endorsement for the Rebus model, relaxed beliefs under psychedelics, and also revised precision weighting of beliefs, a continued relaxation, if you want, post-acutely, at least in particular domains. They're in a domain of negative self-beliefs. Now, I'll close out with our findings in our recent 2-arm double-blind randomized controlled trial of psilocybin therapy for depression, where the short story is that the pre-registered primary, there was no significant separation between the conditions, and yet all of the other secondaries significantly favored psilocybin therapy. Make of that what you want. Always look at the data and the findings and draw sensible inferences, I would say, but pretty promising in a head-to-head with the gold standard first-line treatment for depression and SSRI. And now, a key question is what passes these two treatments, and I've only got 1 or 2 slides left now. And here the hypothesis ahead of the trial was that emotionality is going to be a salient domain to look at. And so we looked at that with some already validated measures like the Lorck's emotional intensity scale, saw clear separation on that, where there was some attenuation of emotional responsiveness with escitalopram and an augmentation with psilocybin. And here, these are just self-constructed items that very clearly separated between the conditions, the ability to cry being increased. This is post-acutely at 6 weeks at the end of the trial, increased with psilocybin, ability to feel compassion and intense emotion, creative feelings, feelings of pleasure, ability to concentrate as well. All these positive items were favoring psilocybin with some robustness. And we can dive into the mechanics a little bit, my last slide now, and look at the brain's responsiveness as seen through fMRI after treatment at the primary endpoint, 6 weeks at the end of the trial, after 6 weeks of escitalopram, or 3 weeks after the second of 2 doses of psilocybin therapy. And what we found in this metric was that escitalopram had the big effect. Psilocybin really didn't have much of an effect on the brain's responsiveness to emotional stimuli. In this case, they were emotional faces, whereas escitalopram very reliably attenuated the brain's responsiveness to these emotional stimuli. So that was curious. And I think this speaks arguably to the action of escitalopram and maybe other SSRIs, buffering against strong emotion, incubating against stress, you might say, whereas psilocybin doesn't seem to do that. So it does something else, which is interesting. Maybe relaxing and revising canalized assumptions underlying different flavors of psychopathology could be the specific action of psychedelics. So I'd like to thank you all for listening, for my colleagues who helped me along the way, and those who backed my research. So thank you again.
Thank you very much, Dr. Carhart-Harris, for that wonderful presentation. And we have some questions in the queue. And as a reminder, you can still submit questions through the Q&A function in your attendee control panel. So some questions are regarding the mechanism of the psychedelic psychotherapy. And it was mentioned about increased learning under the influence of a psychedelic. And what are your thoughts about the role of learning mechanisms as pertains to how the psychotherapy actually is working to enhance the benefit of the psychedelic medicine? Yeah,
well, I think there's a specific action on learning. So it's not it's not the learning of high level, difficult, cognitively challenging information that could be enhanced by psychedelics. If anything, one could imagine that there being an impairment in that direction. But low-level implicit learning, associative learning, I think could be accelerated in a dose-dependent way by psychedelics. I think it's easy to intuit that could top out at excessive dosages, but at lower doses, I think, and the evidence is backing this up. We're about to see a paper published in collaboration with another team looking at accelerated learning rate with LSD in humans. Look out for that one, Kanan et al. In Psychological Medicine, I think. So, it's that acceleration of learning rates where that maps also to unlearning or extinction learning. And arguably that may be the more salient dimension when it comes to the action of psychedelic therapy, and specifically the de-weighting of pathologically overweighted ways of thinking and or behaving.
Okay. We have a question with respect to neuroplasticity and the idea that psychedelics and many interventions can impact neuroplasticity. What are the implications for that regarding the pathophysiology of depression? Is depression fundamentally an impairment in neuroplasticity that these interventions can address?
Yeah, well, I think arguably, one if not the most reliable finding in psychopathology research is cortical atrophy under adversity. So in animals, it's chronic stress paradigms causing a degeneration of synaptic spines. And in humans, you can see this across the board in psychopathology, and also in individuals with a background of significant childhood adversity, for example, is a cortical thinning. So it translates across species and it holds up. So that's the picture. That would be the picture in depression. You could say that's related to neuroplasticity, or really rather neuroplasticity may be the solution. It may offer a synaptic replenishing, an increase in what more accurately should be described as heterosynaptic plasticity. So it's the growth of synaptic spines that are involved in that are allow for more possibilities in terms of synaptic connection. So even at that very low level, I think there's a hint to a therapeutic mechanism of action which could actually apply at multiple levels. This sort of broadening of the ability to think and behave more flexibly and more openly.
You showed some really interesting findings about decreases in modularity and the relationship with outcomes. What is the specificity of that finding? And there's the question in the chat was, does cannabis also decrease modularity, increase entropy?
Oh, I don't know. It's a great question. I don't think so, but I don't know. I mean, that's a good test. Another good test would be a psychostimulant. I've been sort of knocking on the door of a few preclinical researchers to encourage that they look at, ideally in the same animal, a psychostimulant and a psychedelic to test this question of specificity. It's a key one. When you find a sensitive measure, meaning it'll do things like correlate in its magnitude with some behavioral outcome, important behavioral outcome. So it's sensitive, in a dose-dependent way. It'll move in a predictable direction. But is it specific? There are other interventions that could do the same thing, and that becomes the next, key question. As things presently stand, I haven't found any literature suggesting that other compounds that do anything that is unrelated to a psychedelic or psychedelic-like action can increase signal complexity in the cortex with the same robustness, and reliability. And that's what we need to see. So whether it's cannabis, which could broadly be said to be kind of psychedelic-like, but what about a psychostimulant, which I would say moves in a dose-dependent way, typically moves consciousness in a different direction? I think there's some evidence that psychostimulants increase modularity or the sharpness of segregation between systems. And also that relates to cognition. Generally, modularity going up is actually related to improved cognition. Yeah, there's some interesting questions in that direction. And it's a great question to ask about specificity. More work in this space is very much needed to test the specificity of these relationships.
Another question regarding the brain imaging findings. You presented a lot of interesting findings. There wasn't much of a discussion of laterality of effects. So the question was with respect, are you seeing significant laterality effects?
As time goes on, I was one of those who were like, that's kind of pop, pop neuroscience, and it's oversold, and it's an oversold narrative that's not really there in the peer-reviewed literature. But I don't know. I'm seeing things with things like TMS, focused rapid TMS, and it seeming to matter what hemisphere is being stimulated. And so I'm relaxing my priors to see what comes through. With psychedelics, typically things have looked quite bilateral. And it hasn't, I would say it hasn't screamed through in the data, like a specific lateral or hemispheric action. But what's happening now, which is great, is that different teams with imaging data are collaborating and sharing data. And there's a sort of big-ish data initiative to have a look. And it's a nice reminder that I drop in that suggestion to the team, the broad team, that we might look at laterality in these bigger data. So nothing obvious, but I wouldn't rule it out.
Okay. Well, thank you, Robin. And I think this would be now a great time to bring in the rest of the panel, and we'll continue the discussion with you. I mean, there's still a number of questions of a more clinical flavor. But at this time, I'd like to welcome the other panelists, which include Stephen Ross. Stephen Ross is a research associate professor of psychiatry and child and adolescent psychiatry at the NYU Grossman School of Medicine. He's a founding member of the NYU Psychedelic Research Group and is currently associate director of the Center for Psychedelic Medicine and director of the Psychedelic Medicine Research Training Program. Rachel Yehuda is an endowed professor of psychiatry and neuroscience of trauma. She's also director of mental health at the James Peters VA Medical Center. And she established and now directs the Center for Psychedelic Psychotherapy and Trauma Research. And then Greg Fonzo is an assistant professor in the Department of Psychiatry at Dell Medical School at the University of Texas at Austin. And he's leading efforts at UT Austin to understand how psychedelic-assisted psychotherapy augments neural and psychological functioning. So we will make this hopefully a very interactive panel, and we'll soon open the floor to audience questions. So please send in your questions, and thank you for submitting your questions to this panel. And I know as there are a lot of clinicians in the audience here, we will hopefully address some of your clinical questions. And so I'll start off with a very clinical perspective. How can clinicians who are sort of actively seeing patients with depression, PTSD, and so on, and a patient comes to them and they read all the media reports about psilocybin, they've read all of your research and published findings and lay media outlets, and they're interested in signing up. What do you tell them? And so any of you can take that question.
Well, I'll just jump in. I think the first thing is that these drugs, if we're talking about the serotonergic psychedelics, are all Schedule 1. So they're not clinically available or prescribable. They're only available in research contexts in the United States. So the short answer is they're not available to people legally, and would not recommend that people do it. I mean, there is an underground here, but I think it's important that we don't get ahead of the data, that there can be sensational media reports. People can think that it's going to cure whatever, and they can just go get psychedelics wherever and take it without context. And so we need to do much more research to establish whether they work or they don't. And if they are available and prescribable, there'd have to be a context there to do that, to optimize safety and efficacy. The only psychedelic that is legally available is ketamine. If we were to talk about that, and that's a whole other kettle of fish to discuss. But yeah, that would be my answer on this one.
I think, I mean, you also touch on almost a definitional question, Steve, regarding ketamine. How is a psychedelic to be defined? Is it to be defined based on mechanism? Some would argue MDMA, of course, is not a psychedelic, but an empathogen or something different, since it doesn't directly impact serotonin two-way. How do you all define psychedelics?
Well, I think it's a vague term. I mean, it started with Humphrey Osmond. Mind manifesting is vague, and the original classification were the serotonergic hallucinogens, the 2A agonists. So you can break it out mechanistically. If you broadly include ketamine, you're talking about NMDA antagonists like ketamine, phencyclidine, nitrous oxide. If some classifications even include MDMA, which has very weak effects at the 2A receptor. It is a whole other kind of mechanism and pathogen. So I think when you say psychedelic, because it's such a vague term, you have to be specific about which mechanistic class you're talking about.
Yeah, I would agree with Steve on that. I think that, I like how Robin noted in his presentation, classical psychedelics is kind of a term that's used to describe things like psilocybin and LSD that are 5-HT2A agonists. And that really does kind of help to homogenize the definition a bit. But the term itself, psychedelic, is a little bit ill-defined. And it's up for question in regards to how that should be defined. If it's in regards to sort of a substance that induces a massive shift in consciousness for an acute period of time that can have a therapeutic property, then ketamine could be included in that class, MDMA, as well as probably several other compounds as well.
I briefly also add that it's probably discoverable. If you could define it by the pharmacology, but then what of the psychedelic-like compounds, like ketamine? They're not stimulating the 2A receptor, but maybe they're doing something else which shares some similarities in terms of the brain action to the classics. And, they increase glutamatergic function, for example. I think it's discoverable. It might not even be too far away, in terms of a brain effect that could be offered as a definition of psychedelic action.
And I might jump in here too, because there is no consensus definition of what is a psychedelic drug right now. And then the question is, should there be? And if there is one, do we want to focus on mechanism of action or class of compound or what these compounds do in the brain? Because the way that society is talking about what psychedelic drugs are is weighted very heavily on their subjective effects, how they make you feel, things that are not very well defined in science. And so, really we're left with the word psychedelic, which is mind manifesting, really. And as a field, this puts us in a really big dilemma, because we're really used to defining things the way you just heard in this brilliant presentation, according to receptors and how these things work in the brain and what is the target and are you reversing the target. But when you talk about psychedelics, you're not only talking about subjective effects, you're talking about things like set and setting, the intention that people have when they take the drug, how they're taking the drug, a lot of it has to do with the psychotherapy that occurs before and after the drug is taken. And those things are not easily defined in a purely biologic context. And so taking the same compound in the course of a psychotherapy assisted process is very different than taking it at a rave or at a festival or for recreation. And that also presents very interesting dilemma for translational research or for brain research. So when we talk about psychedelics, we really need to have a much broader conversation. And just to say one word about your first question, which was really very provocative, what should therapists do if their patients come and say, hey, I think I would like those magic mushrooms or MDMA, because it is all over the media and there is a lot of hype. It's increasingly being presented at conservative forums like this, which are educational for clinicians. And I think at this moment, as they are not broadly available or legal, what I would do is really interpret this in a very psychological way as a wish for more. If this is a patient that you've been seeing for a while, who now comes to you and says, I need this other thing, it's a very good opportunity to discuss what is and isn't working, and really to have some candid discussions about progress or lack thereof with the kind of therapies that the patient is currently getting. And then for both of you, patient and therapist, to embark on learning more about what is and isn't possible. If the idea is to assist a psychotherapeutic process, it's possible to access altered states, not only with psychedelics, but with breathwork and other kinds of things that are legal. So it's really not a question of who can I call, how do I get this drug? It's really about listening to the fact that your patient isn't getting something that they need and really being wildly attentive to that.
Well, thank you. So this next question relates to this issue in that many practitioners are interested in becoming experts in this area and conducting in their offices or programs at home a psychedelic informed psychotherapy. And there's a number of workshops and seminars that people may be attending and so on. How do you sort of see these? Are they legitimate? Is there any of these training programs that you would recommend and so on? I mean, the objective of the ADAA is to give evidence-based recommendations to our clinicians and patients. And so I'm curious what you all think of the training programs out there. So anyone can answer that.
Yeah, it's, oh, go ahead, Rachel. Did you want to go?
Please.
I was just going to say, I think it's a very good question. And at the moment, there really is no way to regulate or determine which of these programs is, quote unquote, the most evidence-based or the best. So, the two that I'm aware of as being the oldest are the MAPS MDMA assisted psychotherapy training program, which is specifically focused on MDMA assisted therapy, as well as the psychedelic assisted therapy practitioner program at the California Institute of Integral Studies. Those are the two that I think are the oldest, or at least the first established. And so the other things I think to look at here is in regards to the breadth of the training and the length and the duration of the training that you get. But at the moment, it's really, I think it's sort of, buyer beware in terms of trying to understand which program might be the best for you and which, if any, is the most helpful in sort of conveying these skills to people.
Yeah, so I'm talking to you from beautiful Ellenville, New York in the Catskills, where we are in the middle of an MDMA assisted psychotherapy training. It's about 5 days long in person and has many modules to it. We're doing it in collaboration with MAPS, who will certify people who go through all the steps. And luckily, due to philanthropy, we're able to offer it for free to people who provide therapy and community programming, who are maybe going to be in a less of a position to access these programs privately and pay a lot of money for them because they cost a lot of money. What you need to understand before you go to any of these trainings, they're probably all useful and valuable, is whether or not at the end you will be able to legally purchase the psychedelic compound you wish to purchase once it becomes federally approved. Because the way that this works is upon approval, the FDA is going to work closely with the sponsor with a risk and mitigation strategy to only allow people who have been trained and certified through a sponsor's program or its designee, which is what our center is setting up. So that if you want to have a more general education about what psychedelics do because you don't know, then any of these programs will teach you that, probably very well. But if your goal is to become a psychedelic assisted psychotherapist, you're probably best off enrolling in the specific programs that are targeted towards either MDMA assisted psychotherapy or psilocybin therapy or any of those programs through the sponsor that's going to be able to have the compound and make it available to you legally, in my opinion.
Any other thoughts on that?
I would just briefly add to that, not to let the cart get ahead of the horse sort of thing, that there's a lot of these programs looking to make money and train people, but as Rachel said, at the end of it, if you can't legally do it, then it's unclear. Also, if the data is not there, it's going to be unclear. But I think, and this is echoing something Robin said, I think the key thing here is the psychotherapeutic context, that these drugs in combination with targeted psychotherapy, I think that's ultimately where the true effects are going to be. And I think it's going to be key that you have skilled psychotherapists in this area that are ethical, stable, grounded individuals. And the data Robin showed about rapport, we know that is the most robust outcome in the psychotherapy literature. And so the people delivering the intervention, their skill set and how they are trained and oversight and supervised, I think will be vital to the future of this field.
Very briefly, it might be surprising to people, but a systematic study of the role of context hasn't really been done with psychedelics. So what we have is a kind of standard, sort of more or less agreed upon standard, that we do the psychedelic therapy a particular way, with the prep, the supervision of the session, and the integration. But none of that's ever actually been tested in a systematic way. We've looked at its variance in it, in your relationship to it, like therapeutic rapport and outcomes, but never actually controlled it as a variable. It's just an interesting thing that people might find surprising that hasn't been done.
We're waiting for somebody to do a factorial design, drug alone, therapy alone, the combination, or placebo. You need to have a big N for that, but I'm excited for somebody to do that so we can start to tease these elements apart.
Yes, but what we do really understand is that the active ingredient for many of these psychedelic assisted psychotherapies appear to be the psychotherapy plus the psychedelic. And so even though you're right technically that we've not done the kind of studies, dismantling studies, what happens if you just give the drug alone and you don't do the psychotherapy, or what happens if you do this in a standard clinical office, as opposed to the beautiful kind of centers that we are establishing for this work. It's true, we have not done those studies, but I think that the most important message to give an audience that is primarily a clinical audience that is really trying to understand the future is, and we are not there yet, and Dr. Ross is completely right about that, we're not there yet, but to really anticipate the future is that this is not like regular pharmacology. This is not that the drug is going to take the symptoms away if you can just get the dose right, or just figure out the regimen. This is about using a mind-altering drug to be able to go deeper into a psychotherapeutic process. In the training that we're doing this week, everybody here has worked, we're doing a PTSD therapy for MDMA. These are people that are experts in PTSD. They've been working with mostly combat veterans for a long time. They know, they're great, they're skilled, they get it, they know all the issues. And now on top of that, we are exploring how to use this tool to be able to go deeper into a process. Perhaps it helps with moral injury or avoidance, or it increases self-compassion, but you still are going to have to use a lot of the training that you have had to date. It's going to be very important and relevant. So this idea that everything that you already know goes out the window, and here just we're going to do something in a totally different way, and you don't really even need to necessarily have the old credentials, but the new credentials, that's not true. What's happening is that most people who have worked with patients get just so far. And as much as everyone's trying to get over a hump, patient is still needing more. And so this might be the little more. And how does it work exactly? Yes, we can study it from a neurobiologic perspective, and we should, but we also have to understand deeply what the experience is of the people that are profoundly impacted by this. And the other thing that's really important and gets lost whenever we talk about biology, just all the time, no matter if it's psychedelics or what, is that there are individual differences in response. For many people, psychedelics are not going to be the answer for whatever reasons, which we will figure out, but that there's just a lot more to it than simply the way that a pharmacological compound is interacting with a biologic entity. It's just a lot more to it than that.
If I could also add off that just a little bit, I think one, in my mind, I think the therapy at the moment, the main consideration there is safety in regards to preparing the person for the experience, making sure they're safe throughout, and that they have, you know, sort of adequate support afterwards as well. But as to whether or not the therapy itself is a key component, I think that's really an open question because, you know, at least the way it's done now, they're really, none of the approaches that are utilized are really evidence-based, right? In the sense of we, you know, would never use the MDMA-assisted therapy to treat PTSD without the MDMA, right? In the way that it's delivered and conducted. So, you know, I think we often get mired in this idea that that the psychedelic is assisting the therapy, but I think we really don't know that at this point, and it's creating a little bit of a sort of an artificial distinction between the idea that maybe there's a synergy there, but it's not that you necessarily need one to facilitate the other. So just into some additional thoughts.
Okay, we have a question about, just a general question about the approval process. And I mean, it looks like the furthest along for potential FDA approval, as Rachel was talking about, is the MAPS program for MDMA and PTSD, which is in late stage trials. There are also late stage trials for psilocybin in treatment-resistant depression. Beyond that, Robin mentioned DMT, and of course, there's studies of LSD. Does anyone care to speak on where those studies are? Is that anywhere approvable in the next couple of years? So things beyond psilocybin and MDMA, which we have heard a lot more about, but certainly there are studies ongoing: LSD, 5-MeO-DMT, DMT, etc. Does anyone wish to address that?
Well, I think from a drug development perspective, just to sort of go back a little bit, so MDMA is the farthest along. There's been a pivotal trial that was very positive. There's another one about to finish. The data is about to be analyzed. MDMA may be like about a year away from being a prescribable medication. And then regarding psilocybin therapeutics, the most advanced programs from a drug development perspective are number one for major depressive disorder, including TRD, but also the data is very strong for psychiatric and existential distress and advanced cancer. And there are programs to move towards pivotal trials there. And at NYU, we also recently published work looking at psilocybin-assisted psychotherapy for alcohol use disorder in about 100 participants. And there's plans to move to a pivotal trial there. So I think with psilocybin, and we're about to get two big readouts of the depression data. A COMPASS trial that included about 230 individuals with TRD is about to publish, and USONA finished a trial at 100 participants. Those readouts will be key to see if in the depression era, there's going to be a path forward. But the other ones are very promising. And then if you go beyond that, everything is in very early stage, phase one. With LSD, the research is just starting again after many years of it being something we couldn't even touch, and people are starting to look at it for various indications. You know, short-acting drugs like 5-MeO-DMT, people are excited will be a quick pharmacologic intervention without psychotherapy that will help depression. I'm pretty skeptical about that approach. We'll have to see the data, but yeah, everything else is quite early at this point. But in the historical era, the strongest data, and by far, was the use of LSD to treat alcohol use disorder, followed by the use of LSD-assisted psychotherapy to treat existential distress and end-of-life cancer.
Just to follow up on your skepticism about the 5-MeO-DMT, is that because there's not a psychotherapy platform associated with it and it focuses exclusively on drug effects?
I think the problem is, as pharma has jumped into this and people are trying to capitalize, is the idea of a short-acting drug where you don't need two therapists that can be delivered and can work just as well is appealing, but I think very problematic. That you know, in that kind of model, you could have bad outcomes. You could have no efficacy and worse bad outcomes, and you could have a repeat of how the field was shut down with really bad outcomes. So I'm open to seeing what happens there, but I'm concerned about that kind of a model.
Yeah, I think the distinction there too with 5-MeO DMT is the way it's delivered. It's such a rapid onset and so quick in terms of its effects that it doesn't really make therapy, possible in the context of the experience itself. At least from what I've heard of subjective reports. I agree. I think there needs to be some monitoring done. There needs to be some preparation and probably some psychotherapy afterwards to help the individual through that process. But if we think about, that if the sort of quote unquote, as Robin pointed out in his slides, if the mystical experience component, right, or the subjective transcendental component of the experience is really important in terms of short-term outcomes, then it's something that facilitates that even in the absence of a psychotherapeutic relationship might actually be beneficial. But I think we always need to be concerned about safety. I think that's really the main consideration.
I think there's another point in all this. Science is going to move slowly and approval is going to move slowly, but politics is going to move quickly. And there are many states now that are not only decriminalizing, but maybe going to start to legalize. We're going to watch Oregon very carefully and maybe other states as well. So even though these drugs may not be federally approved for a while, we're still, as a mental health community, going to have to deal with their availability and how people are going to use it. And our stance on understanding what these drugs are about is very critical here, because we don't want to be left out of this conversation. And we don't want people to be saying, oh gosh, conventional therapy, they're 10 years behind all of this. I'm just going to go to Oregon and find somebody that knows how to do it. Like many veterans are traveling out of the country to have ayahuasca and ibogaine experiences. So I'm not judging any of that. I'm just saying that for mental health patients, usually a lot more is needed than a psychedelic journey before, sometimes during and after. And so we are going to have to contend with the impact and effects of psychedelics and find a way to be able to talk to our patients about it. Some of them may come to us and tell us that what they did that weekend was a group journey with mushrooms, even if you may have discussed this a month ago and decided, and told them logically and carefully that these drugs are not approved yet. There's an enormous amount of curiosity, and there's an enormous amount, let's face it, of frustration that people have because their outcomes are not as good as they hope. And so I think we have to really face those facts in a responsible way and not just say, oh, well, it's not available yet, so I can't talk to you about this, because we're going to have to find a language and a way to provide the sober, correct, cautious information and help our patients with their struggle to improve their outcomes.
I couldn't.
Oh, go ahead.
I was going to briefly say something in response to that. I couldn't agree more. We have to meet our patients where they're at. I mean, historically, a couple of years ago, if a patient mentioned they were going to do a psychedelic session to any psychiatrist, the psychiatrist would say, oh, God, that's crazy, or they wouldn't engage with them at all. And I think we have to meet our patients where they are and practice harm reduction. If someone's going to do this and their intent to do it, we shouldn't abandon them. We should, help them optimize it for safety.
Rachel mentioned patients maybe traveling for ayahuasca treatments and so on. A question in the chat is the concern about from a neo-colonialist perspective. What suggestions do you have for preventing re-traumatization, colonialization, as the Western medical system discovers these psychedelics? And the example is given of harvesting toad venom for 5-MeO, or companies buying up land in Peru, and so on.
I think a nice model that I'm aware of is in regards to not trying to encroach upon the like indigenous usage of certain plants, for example, or animals in this case. So, for example, the indigenous or Native American tribe using peyote, or the indigenous usage of the Bufo alvarius toad with 5-MeO-DMT. I think, if possible, a lot of these compounds that, if they're going to be used for medical purposes, can be synthesized in a laboratory. That's probably actually a more effective way to get the proper dosing, as well as ensure the purity of the compound. You know, in regards to the sort of tourism that's evolved around this area, it's a very complicated issue, because you have, on the one hand, there's a lot of money, right, that can go into driving that tourism. And you know, and some of the, for example, people or ayahuasca shamans or ayahuasqueros, for example, stand to benefit from that. In addition to the fact, though, it also is sort of a neo-colonialism in terms of appropriating their what we might say indigenous technology. So I think it's a very complex issue, but it's an excellent question, and one that I don't really have a clear answer to.
Thanks. I mean, there's a interesting question in the chat, which Rachel has started a answer to, but I think it's worth talking with the entire panel. Talked a lot about psychedelic assisted psychotherapy, which is obviously a prolonged relationship, often two people in the room at the same time over a number of hours and during the dosing sessions. What are the risks that have actually been found of this? And Rachel, perhaps you want to expand on your answer, and then the other panelists.
From the perspective of the compound, these drugs are relatively safe, and they have been around for a while. Just because something's been around for a while doesn't make it safe, but I think the society has had a lot of experience in indigenous cultures with various types of psychedelics. They don't have a strong neurotoxicity profile. They don't seem to be addictive in that classic sense where we worry. There can be psychedelic drug and other drug interactions that you have to be very careful about. And for some people with certain medical conditions, these drugs are clearly contraindicated. But really the biggest risk is that when you go into an altered state, you can learn something or see something or confront something, and you might not have somebody to talk about it with. And when we're talking about people with extreme mental health issues, people who have struggled with suicide or extreme trauma or really extreme depression, that can be quite a risk, because it's the risk of sort of being all dressed up and having nowhere to go. And really, one analogy that's often used is being cut open, right, for surgery, having the surgical process, and then somebody forgetting to stitch you back up, right? And this process of kind of, so let's close it, let's integrate, let's go forward with a plan. Happen, and to some people it needs to happen to lesser extent or greater extent, but that's the biggest risk that has been noted, that people say somebody opened me up and forgot to close me up. And so that is something we really want to be mindful of. And I saw one question about this being a quick fix. It's not a quick fix. This is it takes a long time to get through one of these courses of treatment. There's a lot of preparation, integration with MDMA. It shouldn't just be going in for a drug and goodbye. It really needs to be staged in terms of a much longer protocol with a lot more surveillance at the end, depending on the level of severity that a person is starting out with. These drugs are very powerful. They're transformative. They cause a major readjustment. You saw the neuroimages, you know, the brain's really reacting to it. So of course, somebody needs to have a process of making some sense out of it. And so leaving a person high and dry after they've had this kind of a major experience, if they're vulnerable to begin with, is something we really want to make sure doesn't happen.
And just briefly echoing that, it speaks to the principle that the proposed therapeutic action is actually the same action that arguably underlies the risk potential of psychedelic therapy, because the therapeutic action is one of opening people up. That's the opportunity. But if that opportunity, that action isn't managed right, then there lies the adverse events potentially.
And just to kind of add on that too, there has been cases reported, right, of people being in a psychedelic state, right, or some altered state, and there being abuses taken by the therapist. So I think that's a major concern here, is about how do we prevent that from happening. A lot of the trials now use 2 therapists per patient in order to help prevent that. There's video recording, for example, as well. But there are several high-profile stories that have come out about this occurring, and I think it's an issue that we're going to have to wrestle with, because people are in a vulnerable state, when they're under the influence of these compounds, and it's something that we need to be very, very cognizant of.
And that's why I'm pretty happy that there are going to be, in the beginning, regulatory controls over who gets credentialed and certified as psychedelic assisted psychotherapists, because I think that is actually the biggest risk we face with these compounds. That I think, in general, we've had to contend with the bad things that can happen behind closed doors of a therapist with a patient, but this is like that on steroids. I mean, when you add psychedelics to the mix of that potential just increases many, many folds, and we are going to have to develop a very careful system of ethics and do public education about warning signs of somebody that is probably maybe not the best person to be facilitating a psychedelic assisted psychotherapy. So I think as our field matures, these are exactly the kind of issues that we will be grappling with. What it will require, though, is academic medicine and organizations like the ADAA and the APA and the ACMP and all these very important organizations to really step in and see this potential issue and develop guidelines and address it. We cannot ignore this. This train has left the station. It's happening. So we can decide if we're on the bus as responsible professionals trained and really provide the voice of sobriety and reason and authority on how these compounds can be used safely and reliably, or as politics will eventually also create opportunities for people to have them without the mental health provider community. That can happen too. It's going to be up to us to decide. I think that's one reason that I feel so strongly about my involvement and the involvement of Mount Sinai in this, because I think I'm delighted that there's so many academic institutions that are now taking this on, not only to learn about it, not only to the kind of beautiful research that you heard about, but just to understand this from a clinical perspective and how to integrate it into mainstream psychiatry and mental health, and how to introduce it to residents and trainees and to the public.
Okay, another question from the chat. We heard about set and setting and how that's important for the therapeutic outcomes. The question is regarding things like the setup and the decoration of the dosing room and those kind of factors. I mean, we've obviously seen those couches and so on. Does any of that play a role in how a patient ends up doing and the magnitude of the mystical experience? And obviously rooms can differ according to facility, but the clinical trials must have had some standardization of that. But curious to hear any of your thoughts regarding the actual dosing room and how it should look and how is that relevant?
Yeah, I think it's a good question and one that hasn't really been studied. That could be, for example, a factor you would vary in terms of whether the person is in a very comfortable living room like setting, or something like a carnival fun house, for example. I think that in my mind, the main idea is to try to facilitate an environment that the person feels safe and comfortable in. So I think that's where a lot of the efforts have gone, is to providing a sort of a home-like environment where people can feel comfortable to experience the effects of the compound. But as to whether or not that really matters in the long-term outcomes, it's an open question.
There's also the music that's really important. So this is a very interesting thing that it's hard to wrap your head around if you're a traditional mental health provider, that the kind of music that's going to be playing while somebody is having a psychedelic experience may actually influence a lot of what gets thought about, and we're going to have to study this if we're going to answer the question you asked. For now, people are avoiding settings that are just too clinical. The person doesn't need to be able to recline or lie down. And, our facilities are beautiful, and patients gasp when they see it in a good way. And I think that it makes them feel important. So is it necessary? Probably not. But, we don't know. I mean, we want to also make this scalable. So I think we want to understand what the bare essentials are versus, the bells and the whistles. So it is a good question.
There is this interesting tension point in the development of psychedelic medicine, where psychedelic therapy is challenging, the dominant medical paradigm, or perhaps more accurately, the pure pharmacotherapy paradigm, drug alone. And it comes through in the translational work, because, say, in the rodent research, generally there hasn't been any control or manipulation of environmental conditions. It's just drug alone. And also there's an effort to develop drugs that don't produce animal analogs of psychedelic action, and yet show animal analogs of antidepressant or some therapeutic action. And there's just this translational gap where what's happening in humans, say with music in every single clinical trial that's been published, where's the music in the animal work? But one solution, rather than just highlighting the problem, is there may be an opportunity in healthy volunteer research, where maybe you wouldn't give a psychedelic without music in a very vulnerable treatment-resistant depression population, but maybe you can do that for the sake of advancing scientific understanding in a healthy volunteer sample. So I just like to make a bit of an argument for the value of doing translational work from healthy volunteers to patient population.
I just want to briefly throw in the story of Eric Cass, the pioneering researcher in the 60s, that was the first to discover that LSD reduced existential distress, fear of death in dying cancer patients. And when he started his research, he viewed this as a chemotherapeutic intervention, knew nothing about said setting, and gave to hundreds of terminally ill end-of-life patients in an inpatient setting, University of Chicago. His first study in about 100 people was, no therapy, no preparation, no nothing. He'd go into the person's room in the morning, he would drop, give them 100 mics of LSD and come back later in the day. And there were no major safety concerns. And he was the first to report decreased fear of death. Later on, he trended towards more of a model that ultimately Stan Groff and others developed at Spring Grove, the model that we have today, the two therapists, the nice looking room, the music and everything. But certainly we don't want to do studies where they gave somebody LSD and put them in restraints, right? I mean, there's some really unethical bad stuff that happened, but the minimum requirements were not totally sure, and we're just going off of the end of this old model.
So some interesting questions, a couple questions about combining these approaches, these medications, with evidence-based interventions, particularly for PTSD. We have a number of evidence-based psychotherapies, including CPT, PE, and so on. So in the case of MDMA, for example, what are your thoughts about combining MDMA, for instance, with any of these psychotherapies that have evidence in PTSD.
I think that in a way, even though the MAPS protocol, they say that the psychotherapy is non-directive, really what it is a form of exposure therapy. You know, you have two therapists, you're directed during the experiences to focus on the trauma. If the patient doesn't bring it up, the therapist bring it up. And under the influence of MDMA with bonding to the therapist and decreased fear response, people go into the trauma. And I think that there's an opportunity. I think it's an important question, what kind of psychotherapy that you use. For instance, in our alcohol trial with psilocybin, the targeted psychotherapy was motivational interviewing, that we took an evidence-based treatment and saw if we could augment that. As opposed to other studies where they basically just give the drug and do some hand-holding and it's non-targeted. And I think we do need to look at the drug plus a targeted evidence-based psychotherapy to see if we can further optimize treatment outcomes.
Yeah, I completely agree. I think that's a very ripe area for investigation. Is how do we optimize the therapy to work the best in conjunction with the drug? Robin mentioned some of this evidence showing that psychedelics can enhance sort of Pavlovian learning or associative learning. And if we know from a long line of evidence in PTSD that that's an important construct that's used to model aspects of the disorder. So one might hypothesize that if you have people engaged in exposure therapy, which is sort of a human therapeutic model for fear extinction, that that would potentially be enhanced by MDMA, even if it's not under the influence of MDMA. Right? This could be more of a long-term enhancement effect that might elevate learning. So I think one other thing I would mention too is I think it's important to properly control for these, because one issue in terms of combining a psychedelic or MDMA with an existing therapeutic model like prolonged exposure, for example, or motivational interviewing, is that if you don't have an appropriate comparator condition, you don't know really what's driving the effect. So if you have just, for example, psilocybin plus MI without a sort of just psilocybin plus psychological support model, it's very hard to disentangle whether they're synergizing or one is better, is really enhancing the other. So I think we just need to be careful in those designs and really kind of design them in a way that we can answer those questions.
I mean, generally controlling, the control conditions is a challenge. Even, we know that the challenge of controlling for psychotherapy is very, very difficult. But there's also the challenge of controlling for drug effects, where because the effects of a moderate to high dose of a psychedelic are so conspicuous, and inert placebo control doesn't quite cut it. So there are real, there are paradigm challenges to the delivery of care, there are also paradigm challenges to clinical trial design that come up with psychedelics. But just returning briefly to the point of learning-based psychotherapies, arguably all psychotherapies are learning-based. So that again might be a common denominator here, that and so any evidence-based psychotherapy that's working on learning, the argument, as I understand it, isn't that you bring psychedelics into that directly, but rather psychologically supported psychedelic experience could serve as, say, a catalyst to the subsequent evidence-based psychotherapy.
It could. We do a lot of hand-wringing about this because the designs are impossible. But let's not forget that the current, at least for PTSD, the current gold standard of CBT, most of those studies that were done using cognitive behavioral approaches used waitlist controls. So nobody seemed to get too upset about that. And in psychotherapy studies, there's no blinding, and nobody seems to be too upset about that. So I think we just need to, we're not going to be able to find a placebo. You're having a psychedelic when you get it. Sometimes with the right environment, you might think the placebo's the psychedelic, but it rarely goes the other way. That's true. And that is a limitation. I think we can work around it. I think the real questions that we have concern whether this is a better idea than the current standard of care. It's not going to be blinded. That's why I admire your study, Robin, of choosing escitalopram. I mean, that wasn't an easy design. It wasn't an easy thing to do. it's ridiculously apples and oranges, right? And you did it anyway, you know, to me, the fact, whether I appreciate the way you presented your data today about the primary and secondary outcomes, it must be very frustrating, but I get it. But even just saying this is as good as the standard of care is like huge, considering where we've started as neurotoxic Schedule 1, this is bad, this is dangerous, this is your brain on drugs. You are reinterpreting this is your brain on drugs in a 180-degree shift. You know, this is your brain on drugs, this is great. Really makes more connections. But, you know, when you really think about it that way, this is important. So the question to really ask is, since these are expensive, labor-intensive therapies that require training and expertise, is whether this investment is going to be worth it, whether a year later somebody's going to really still maintain and strengthen in their gain, or whether they're going to slide back, which so often happens. It's not the fault of the patient. Stuff happens in the environment, and you know, we do a pretty good job holding our patients if they come to see us regularly, but then when they don't, you know, we wonder, we worry. You know, we have very few successes where we never have to think about this again for that person, the mental health component. And the promise here is that this might be a different kind of experience, but we don't know that yet. And so that is the gold ring, whether or not these dramatic effects, even if they're for a few people, are going to be sustained over many years, as people are reporting anecdotally. But that's going to be where we really have to do our surveillance. What happens next year? What happens in 5 years? And unfortunately, these trials are too new to know that answer. But you know, the therapy's got a lot of other things going for it. Robin, I've heard you point that out many times about the side effects of chronic antidepressant use versus, you know, having a mystical experience, you know, and not side effects and other things like that. So we're going to have to weigh all these things together. And I don't think replacing the standard of care with psychedelics is warranted now, or maybe even ever, but offering this as an option and really delineating the kind of people that are most likely to benefit from it is just something I think we need to be doing right now.
And this is probably a good point to just jump in and mention too, that, you know, having a psychedelic experience is not necessarily without side effects, right? That, you know, these can be very challenging sorts of experiences for people. You know, I think what was informative to me was seeing the table that was published in the 2020 Roland Griffiths paper in depression, and looking at psilocybin versus waitlist, and you know, the rates of sort of emotional distress, I wanted to cry, I felt alone, were, you know, upwards of 80 or 90% of that sample. So I think it's helpful that people know that ahead of time, that it's not all mystical experiences and necessarily positive emotions, that there's a lot of tough work that also occurs.
Can be very dark. You can go to a really dark place.
Yeah, and psychedelics are not for everybody. For instance, people with psychotic spectrum illness, you know, that's an absolute contraindication in my mind. And I've treated a fair number of people in my private practice that did not have psychotic spectrum illness, but did too much ayahuasca with sociopathic shaman type person, developed a kind of chronic delusional problem. So people can be seriously harmed by psychedelics, and that is what undermined the field in the 50s to 60s, that they escaped the lab, they were used indiscriminately, and there are real harms associated with that.
Briefly, I think people are probably, you know, hearing so much emphasis on psychotherapy, which is great, and which is great that that's being communicated. It came up earlier about really around the idea of rapid acting psychedelics, that somehow they sort of bypass psychotherapy and give you, you know, a mystical type experience. I'm one of those who's not really a fan of that term. Maybe it's just a name, but there's something to the experience. And I just thought I'd bring it up that that bypassing of the work, so to speak, is, I wonder if others share that intuition that might be where potential risk lies. and some of Steve's comments on being skeptical of the rapid acting. Is it that there is this potential that you bypass some of the psychotherapeutic work?
So it's an interesting question. I think some people have called it spiritual bypass, that you kind of just go straight to the bliss and the euphoria, sitting in the lap of God, quote unquote, so to speak. I think it's an interesting question. I think we need to probably investigate that empirically, to examine if that is the case. The intuition is that, at least my intuition is that it's what you do with that experience afterwards that really makes a difference. And the preparation may not have to be as intense if I don't know, or maybe even more intense, depending on if it's a rapid acting psychedelic. But it's a very intriguing question. And I think it kind of illustrates that there's a lot of parameters around this that we don't yet fully understand.
Thankfully, there's actually some great literature on spiritual bypassing with other interventions, with say meditation retreats. So actually that's come up before when people have asked about what should I read about psychedelics, and they think I'm going to say How to Change Your Mind. And I say it's something more like, After the Ecstasy, the Laundry by Jack Cornfield. So for the rapid acting psychedelics, that kind of wisdom teachings around how to integrate those kind of major transformative experiences could be something to refer to.
And we saw that the work with advanced cancer in the pilot study we did, and did a long-term follow-up of that. The sustained benefit patients attributed to the memorability, significance, meaningfulness of these experiences that opened a kind of behavioral door where they started to meditate or garden or listen to the music again, or were able to very clearly remember what happened that day in an enduring way and to apply it into their life in an ongoing way. I think for that population, it's going to be key what you do with the experience, what form it takes, and how that progresses in a way that's helpful to the underlying disease process.
Well, as we predicted, we had a lot more questions than we have time to answer. Unfortunately, our time has run out. So I'd like to thank the panel for their time. I'd like to thank the audience for the engagement and the really interesting questions. And yeah, we really appreciate your time. So thank you, panel. Just a few comments about ADAA, and if we could just plug our conference, which is happening next April, as you can see here. It's a wonderful conference that integrates science with clinical practice. If you've never attended before, and please register. Join the fun in Washington, D.C. And if you're not yet an ADAA member, we invite you to become a member and join ADAA, and you'll have access to these kind of webinars and other educational opportunities. So again, we thank you for attending this webinar, and please check out the website for more information. Thank you all.